So I'm massively honoured and grateful to be joined by the top expert in trigeminal neuralgia, commonly known as Prof. Zak to her patients and fans. Prof. Zak is a consultant in facial pain and is both dentally and medically trained at King's College London and the University of Cambridge. It's brilliant to have you with us today. I'm Niki Jones. I'm actually have had trigeminal neuralgia myself for over 18 years now, and I've had all the treatments possible, and I'm now really effectively self-managing my pain through the sort of things that we talk about at the Footsteps Festival. So we wanted to just have a bit of a conversation about how I've done it and how you see your patients managing and the whole sort of broader aspects of facial pain. So I suppose to start is, what exactly is facial pain?
Well, it's a very broad definition, and normally we define the face begins from the eyebrow down to the bottom of the chin, and above that is headaches and head pain. But of course that is blurred because the main nerve supplying sensation to the face, the trigeminal nerve, actually extends not just from the chin but right up to the top here. So it's a little bit blurred, but generally we tend to talk of the front of the face as being face pain. And then that includes going right back to the ears as well, but not behind the ears, although obviously some of the pain from the face will be referred to the back there as well. And potentially of the chronic pains, because obviously the acute pain that's most common is dental and always will be. But of the chronic pains, that is pain that's persisted over 3 months, probably the most common one is the temporomandibular disorder, musculoskeletal pain, involving pain really in the distribution in front of the ears, down the face, muscles of mastication, and up potentially into the temple area, a little bit behind the ear and down to the bottom. And that by far is the commonest condition, and often a precursor of other types of pain, often associated with other chronic pain from other parts of the body, such as, for instance, fibromyalgia is very common, that you also have temporomandibular disorder. But then we have a group of conditions called the neuralgic pains, which are on one side of the face only. And these include, of course, trigeminal neuralgia, but other neuropathic pain, that is pain due to injury, be it due to dental injuries, such as extractions, implants, or trauma and accidents to the face. And then we also have the variants of trigeminal neuralgia, the short unilateral neuralgiform pains with autonomic symptoms, so-called the SUNAs. We have the much rarer glossopharyngeal neuralgias. And then we also have those that are more widespread and around more than just one side of the face, burning mouth syndrome, specifically really in the mouth, a burning sensation, particularly of the tongue. We have the persistent idiopathic facial pain, which is a pain we can't exactly say what it is. It's all over the place. But then we have those related to, for instance, post-stroke pain can result in facial pain, cancer, post-surgical procedures. All of those can also result in some form of facial pain, including infections such as herpes. Used to be seen quite a lot, but much less of it now. But what we call the shingles, which then transfers into the post-herpetic neuralgia. And the worst of those is the ones that around the eye, probably the most common, and results in pain afterwards and is labeled as a neuropathic pain. So those are the main ones that we would talk about in discussing facial pain.
Brilliant, thank you. So what sort of treatments are there available for people? I mean, we at Footsteps, we try not to concentrate too much on the medical side of things, but if we have a brief rundown of what people do, because that tends to be when they come to us after that?
Yes, and I think everybody will obviously first reach for drugs and drug therapy. And I think the important thing to remember is that the conventional drugs that you buy over the counter, your paracetamols, your codeines, your non-steroidal anti-inflammatories, really don't work for chronic pain. And just as it applies to chronic pain anywhere else, it also applies to the face pain. So we're going into the realm of drugs that have to be prescribed, and most of them will belong to the group of the drugs used for neuropathic pain as according to the NICE guidelines. So these are drugs like the tricyclic antidepressants, amitriptyline, nortriptyline. Then we go into the newer ones of the anticonvulsants, gabapentin and pregabalin, which of course now are very much more restricted as they've become controlled drugs. And then we talk of trigeminal neuralgia being managed much more clearly with anticonvulsant drugs, of which the first one is always carbamazepine, oxcarbazepine, lamotrigine. So highly specific for just that one, whereas the other neuropathic pains are much more likely to be managed with amitriptyline, possibly duloxetine for postherpetic neuralgia. But I think alongside this, rather than as at the end, which is often what happens, is the biopsychosocial aspect of managing it. Because we as medics, we only see our patients 2-3 times a year, but the patient has to live with it continually. And so this ethos of having to live with the pain and learning to understand what makes it better, what makes it worse, how you as a person can influence that pain is hugely important. And the only treatments that are surgical really in the face are those related to trigeminal neuralgia, which can be very successful in the correct patients. So surgical management remains really the domain of trigeminal neuralgia, and hence the importance of getting the diagnosis right, because you don't want to be operating on patients who haven't got trigeminal neuralgia. And the big one here is, in fact, comes up temporomandibular disorder, TMD, particularly if it's on one side only. And it can be confused, particularly if it comes and goes, can be confused with trigeminal neuralgia. And my colleagues in the States say that some of the neurosurgeons, in fact, don't get this right and do operate on patients with TMD because they don't realize the subtle differences. So it is about really concentrating hard on the diagnosis and immediately for treatment saying, it's a two-pronged treatment. There's the drugs on one side potentially, but alongside that has got to come self-management.
Absolutely. I mean, it's, as you say, we see our health professionals a couple of times a year sometimes, and we're living with ourselves every minute of every day. When I started to get trigeminal neuralgia and I started going through, you look at forums and stuff, there's an awful lot of fear involved with facial pain and TN in particular. It is an excruciating condition. It is intensely painful, and it's very frightening because it appears out of nowhere, and it's hard to sort of figure out when the pain's going to come, and you start slipping into fear avoidance cycles and stuff like that. It's hard for patients to sort of grasp these concepts and step out of fear. How do you as a clinician try and help people do that?
I think it's identifying it is very important for patients to tell us how fearful they are. Sometimes patients think that we don't want to know some of these things. We often will pick it up on questionnaires as well. I like using questionnaires. Something like the pain catastrophizing questionnaire will tell me about some of the fear there. There's also specific questionnaires on fear avoidance. So I think the first thing is identifying that it is a problem. And I think for patients with trigeminal neuralgia, it's it's a said, it's a done. We know that because of its unpredictability and its extreme severity. I mean, it really is, as I don't like using the term, but it has been called the suicide disease because of the severity of that pain. And so I think allaying fear is very important. And I think for that reason, having a very clear care pathway is so crucial, that patients know their diagnosis, that they are told where to go for help, they are given manuals, they're given information. We like to, all our drugs prescribing is on a information leaflet, which is not only given to the patient, but also to the GP, because GPs haven't got a lot of these cases, so they don't know how to manage them. And then we have a particularly trained nurse, a clinical nurse specialist, who's an independent prescriber, who they can ring and have a consultation with if they don't feel sure about what to do with their drugs. Sometimes they don't want to hassle the consultant, but they will phone the nurse, and our nurse can give them the information they might need, alter their medications if necessary, contact the consultant if necessary, and also then contact the GP, because sometimes GPs don't know how to prescribe and don't know that patients need to be on what I call a sliding scale, but means that patients do have to alter their drug management. Now, in some conditions, you don't alter your drugs. Once you're put on a set of drugs, that's it. But in trigeminal neuralgia, you do alter the doses. If you've got a flare-up, you need to be able to know how much to increase, how safe it is to increase. And that's something that patients need to learn by keeping some diaries, so they know how they respond to each of the drugs. And if a particular drug stops being effective, that they know that there are other drugs available. And then also knowing that potentially there is a surgical option as well. And so what we have particularly at UCLH encouraged is a joint clinic that patients come as soon as they've been properly, as I called it, phenotype, that is, the diagnosis has been established, and we have got an MRI scan, we have a joint consultation. That is a surgeon, a neurosurgeon, a skilled neurosurgeon, not just any neurosurgeon, and the clinician, the physician, that is, in this instance, very often myself. But a combination of a physician and a surgeon is crucial. And then we go through the scan and we go through the options. And I like to give, at the end of that consultation, a decision aid. I actually use the Ottawa decision aid, where we write down what the particular options are for each patient. Because some patients, for instance, yes, a big operation would be an option, but their medical condition doesn't allow for it. So that will drop down to a bottom of the list. So patients are given a clear mandate. These are the options available to you. You don't need to have this treatment at this particular moment in time. And then they continue to be managed by the physician, but they know there's a neurosurgeon there. So if they have a severe flare-up, they know they contact us, that is the neurosurgeon or myself. We can admit them, because we have a policy that we can admit these patients under the neurosurgeons, and we can potentially do some of the smaller operations later on. And so patients have a clear pathway and they know who else they can go to. The other factor we have is we've set up a pain management program specifically for our TN patients, so that they meet in a group with a psychologist and a physio. It's 6 sessions, and they learn techniques such as you've got here of mindfulness, meditation, dealing with a flare-up, reducing the isolation, and very much trying to reduce the fear. And that's a very important program, that patients get to know each other, get to know the rest of our staff, so they feel in a way protected. And I hope that reduces the fear, because they know for each of those steps who to contact. They've got the contact details and they can contact us. And they are being very resistant, not surprisingly, to being discharged. So luckily, for instance, our trust now allows us to do what we call patient-initiated follow-ups. So patients are not discharged so that they can contact us in an emergency again, because trying to get re-referred to a secondary or tertiary centre can be extremely difficult, and we know how overworked the GPs are. So by keeping the patients on without discharging them, I would like to think that we reduce the fear. So it's about patients developing a clear care pathway and knowing who to go to for the different procedures.
It's that sense of control, isn't it? That TN
Yes.
in particular, you lose that sense of control. So to have a clear pathway like that is massively useful. Certainly, I'm looking back at my own journey. It was the times I fell out of the pathway that were the most disabling for me in a lot of ways. So somebody with TN shouldn't really be managed just by a GP. Then they should be being managed by a multidisciplinary team, shouldn't they?
Yes, I think that's what the NICE guidelines on neuropathic pain state particularly highlight, that patients with trigeminal neuralgia should be started by GPs on carbamazepine, and if that starts to fail, either because of poor pain control or tolerability, they should be referred to centres, secondary care sectors. What we still haven't got, and what I'm working on, is to develop these centres of excellence. I would like to see centres where we have both a neurosurgeon and a neurologist together who work as a team and have the support of the psychologists, physios, clinical nurse specialists, because I think, as you're saying, it's being in control that is so crucial. If you feel that you are in control, I think you manage this pain so much better.
I mean, I know a lot of people sort of resent the idea of a psychologist being involved, because they see it as you saying it's all in their head, which of course we're not. I mean, pain is very, very real, but psychology has a very important role to play, doesn't it?
Yeah, I think so. And I think that's what we're beginning to understand more and more now. As we can do functional imaging of the brain, we've now come to understand there are areas that are labeled as pain complexes, but equally we have got cognitive areas, emotional areas, and we can see how those light up at different circumstances. So, and very simple tests that have been done about what's called the cold pressor test, where you put people's hands in very cold water and look at how they react. And they've shown, yes, this pain is registered in the brain, but it depends what that person is doing at the time when that hand is in that water. Are they thinking of something pleasurable, or are they thinking of the dread of this getting worse? That affects both the amount of pain they have and what emotionally and cognitively is shown on the scans. Equally, even somebody who's with you, the person with you, can also alter the way that this pain is perceived. And there was a very small study done in France looking at patients with trigeminal neuralgia under a functional imaging process. They were all told that they would have their pain stimulated at one point to see where it records in the brain. But there were a few that got pain in between, that is, not triggered by them being touched. And what they found when they looked at the scans, it was then more the emotional and the cognitive parts of the brain that were beginning to be active. These patients knew that they were going to get pain at some stage. And it was the fear, the unpredictability of when was that attack going to, when were they going to be stimulated, that set off extra pain. So we now know that emotional and cognitive factors are extremely important in managing any form of facial pain, or any pain, in fact, any chronic pain.
Yeah, absolutely. I mean, I've used them to great effect also. And TN is particularly sort of characterized by these trigger points, and the fact that things like light touch and wind can trigger off this excruciating pain. Do we know why that is, in sort of biologically? then you obviously add, as you say, the fear and the almost a conditioned response, isn't it, as well?
To some extent, yes, but we don't know the whole story because it's what I call a multifactorial disorder. There's several things that go wrong. One of the principal ones is that as the trigeminal nerve traverses from the front of the face to the back of the skull to enter the brain, because the nerve doesn't enter the brain proper until at the very back. In that short journey within the skull, there can often be some big, large vessels, particularly superior cerebellar artery, that can press on that nerve. Now, pressure exerted on a nerve can reduce the insulation between different nerve fibers. Now, the trigeminal nerve carries a variety of different types of nerves, those for light touch, those for cold, vibration, sharp pain, light pain, and they're normally separated from each other by insulation. But if that insulation is broken down and the fibers are squashed together closer, that can then generate a crosstalk, just like when you touch a live wire. Suddenly you get a shock. And so once the system has got itself sort of out of it, it's done the shock, it can't get shocked for a little while again. And then the body also tries to mend that myelin, and the mending can therefore result in these periods when we have complete remission. But it's not the whole story. There's also, we've now found, what we call sodium channels. Sodium, potassium, calcium channels are the way that nerves transmit their information. And what we've found in patients with trigeminal neuralgia, that their sodium channels are not working properly, and they don't stop transmitting. And so this is where we get the problem, that these signals are not inhibited. So that's why the drugs we use are what we call sodium channel blockers, which stop some of that. But there's been some studies to show that even after a successful microvascular decompression, some of that inhibition still remains. And there could be other reasons for it. And I suspect there are going to be other reasons for why we have trigeminal neuralgia, but those are the sort of basics of what we think is happening.
It's like if you try and find any kind of sort of causative factor between patients, you just get a mess, don't you? There's no sort of unifying experience or anything, which is fascinating. And I mean, I had a massive compression on my nerve root, and I had a microvascular decompression very quickly, which worked. But then I had huge emotional trauma with being made redundant from work, and I was tapering very fast off the drugs. So, you know, it's almost a trigger stacking. You end up with different compartments, and it's that all contribute to the pain. And it's looking at what you can do personally, what to reduce those sort of contributions to it, which is what I've done. I said to you before we started that I could actually be in quite a lot of pain today because, you know, but I manage it in a different way. I'm not frightened of it, and I know that after this I'll be spending quite a lot of time outside, which is always the, you know, relaxing and useful.
Yeah, and I think that's very important, as you say, that there you are, you have been found to have a big compression, it's been dealt with, and yet 70% of patients do well, but there's a 30% that don't. And that indicates that there is another mechanism, which then perhaps trumps the mechanism that we initially found, and that becomes the more important one. But as you say, I think that's what you have shown is how important it is to think of it in a different way. And that makes a huge difference to the way you're managing it.
Yeah, for me, the sort of crux point came when I let go of the idea that I needed somebody to fix me, that I needed a doctor to fix me, that there was a, you know, a biomedical sort of fixes. Things might help, but I actually had to take control myself. And, you know, I had responsibility to do that. I mean, we call it biopsychosocial, and the social does do quite a lot of heavy lifting because obviously there's a lot of social determinants for pain. But there's an awful lot we can do ourselves in the psychology aspects and in the way we live our lives. You do have to do a lot of lifestyle changes, and it's very difficult, and it's very hard to do alone. And I think that's what's important, and what we're trying to do in Footsteps is to show people what's out there, and also that they are not alone, and that there are, you know, other people who understand. Because particularly with TN, it's very frightening when you look on the internet and, like you say, you know, it's all very, very aversive and very frightening messages that you get. It's hard to access some sort of positive messages about the condition, which is partly why I tell my story, because hopefully it's a positive one.
That's right. And I think that's the important thing, that there are a lot of frightening messages out there, and potentially because people who get better don't want to take part in any other social media, and they move away. So all we're seeing are the ones who are in trouble, and I think that's what you've shown. And I think it is, like you say, it's about having support that's important. It's why, I mean, Alcoholics Anonymous, Weight Watchers, they're not stopping you putting on weight or alcohol, but they're there to help you monitor. And I think what you're doing in Flipping Pain is exactly that. You're there to help people so they don't feel isolated. They've got a shoulder to cry on if necessary, somebody to support them in a positive way. So if they're not sure what to do, they've got somebody to go to ask for some help, positive help, I think, as you're saying, which is so important.
Yeah, and there's the TNA as well, isn't there, which have support groups and stuff like that. And I think I always used to say this on forums, that there is as you say, there's a natural selection. The people who recover, who just don't hang around because they don't need to. And that's very difficult to get across to people, because
and I think you're right that the Trigeminal Association is an important organization for patients to come to, because it has got a medical advisory board, of which I'll show my bias, I'm the chair of it, but patients can get medical advice. So the helpline people can, if they're not sure how to answer the questions, can look at that. We've also, as you've mentioned, we've got a forum out there, which we were concerned about what was coming out on that, but we've now, we actually had a linguist who analysed all the messages on there and told us of the value of this forum, about how important it was for a buddy system to be there, but warned us that we do need to monitor it and make sure that the messages on there are positive, or even if they're negative, but somebody is checking that they're not the wrong messages. Whereas what worries us so much is out there on social media, there's nobody controlling it. Whereas TNA knows that whatever it's got on its website, or whatever it sends out to its members or does through the latest of webinars, has been approved by the medical advisory board. And I think that's the strength of a support group, just like you've had so much support from the appropriate people to help with Flipping Pain as well. You've had the psychologists, the physios, the medics also helping to make sure that the support that's given there is according to the best evidence that's out there.
That's it, exactly. We try to make sure everything's sort of evidence-based and safe, because, as you say, it's a bit of a free-for-all out there in social media land. I also find that that there is, we talk about the placebo effect, but there's a nocivic effect as well. I mean, I look back and I think that some of my triggers were, my brain made associations that I might not have done if I hadn't sort of been reading about them and stuff. I actually deconditioned most of my triggers. I can touch my face now. I can, cycle in the wind. At one point I had to cover everything up, and that's again that's an example of the fear cycle, how you just spiral on down, and how difficult it is to get out of it, and which is why this kind of thing and peer support and the right medical support is so important. But it's a very human reaction, isn't it? I mean, there's nothing about this that is unusual reaction. It's these patients, we're not weak, or it's a horrific pain. We're reacting in a completely natural way.
Exactly, and in a way that you would expect. I mean, if you sort of didn't react, one would be worried about it as well. And I'd like to pick up on what you're talking about, placebo, because it resonates with all pain, that we all have a placebo response, and to some extent in previous years it's been downplayed, and it's a nuisance when we do randomized controlled trials that people respond to it. But now we're realizing that the placebo response is very important, because it brings out your own endorphins, your own analgesics, and that we need to be helping to extend the placebo thing. And this is done very much by expectations, your positive expectations, what you expect from a treatment. And in fact, interestingly, I was at a conference where they were talking about how people were even told, I am giving you a dummy drug. And yet, because they were being given something, that they were being monitored, they had a placebo response, and they did much better than those who didn't get anything at all. So enhancing the placebo response is now, I think, very much a positive thing. But as you also said, there is a nocebo response, that is a negative response about the fact that if you touch your face or try and eat, it gives you negative feelings, as well as drugs give you the adverse events. And again, as you've just said, you can work on those to try and change those. And I know in our pain management group, we had a patient who hadn't eaten pasta for years because he recollected that pasta in the past set off his trigeminal neuralgia. But over the course of the pain management program, he actually got back to eating pasta, and he's delighted that he can eat his pasta again, because he did just like you did, learnt to decondition that nociceptive response. So I think we've now realized that we have to enhance the placebo response. It is a good response, but try and do work towards reducing the nocebo response rate, which is very much more done by the way we think of things and manage them emotionally.
That's it. I mean, the other thing that, of course, that comes with chronic pain is emotional problems, because it's a bit depressing to have it. But we're actually finding that the chronic pain and depression are very closely, and anxiety are very closely linked in the brain anyway, isn't it? So
yes,
actually working on these emotional effects benefits both of them. I mean, you're seeing that in your patients.
Yes, very much. We find anxiety, depression is very high. And yet in our cohort of patients who we've followed up over the years, and in fact published our data, are showing that we reduce depression and anxiety as patients learn to manage their condition, as we give them either drugs or surgery. And I think the big message we've got coming out of our unit is that the prognosis for patients is not as bad as it is initially thought to be. Some patients, and even in my old book, I've got patients reporting how being given that label, you've got trigeminal neuralgia, and then they look it up on the internet somewhere, just absolutely floors them and puts them into deep depression, because they just suddenly think that they're just going to be in this severe pain for the rest of their lives, and there's no treatment for it. So I think what we found, yes, 53% of our patients end up having surgery, but we've got another 46% who never need to have surgery and are managed on drugs. And even in that group, about 15% are able to come off their drugs for a while. They don't need them the whole time. They use them intermittently. So I think what we're trying to get out is that this careful care pathway is showing that the prognosis of trigeminal neuralgia is not as negative as it's been made out in the literature so far.
Yeah, definitely. I mean, I'm meeting people who use the app that I use to help my recovery, and in that space who are doing really well with just really effective self-management techniques and reducing the fear and getting back to life, doing valued activities, having fun and creativity. It's so important as a part of life, because the first thing that goes when you're in pain is all those good things, because I don't know, we're human, I suppose that's what happens. But again, it's hard work and it's a commitment, but it really does work if you can do it. And it's the focus on the pain that the brain gives you more of what you focus on, doesn't it? So
yeah, but I think you're absolutely right. It does take hard work. It doesn't happen overnight. And I must admit, I have some patients who say, oh, I've tried mindfulness, I've tried meditation, I've tried this, but they haven't tried it for long enough. And I know that our psychologists were also teaching us to do mindfulness, and we had a whole session on it. And they were saying, you're not going to be able to do it in one session. This is only just a taster. And I think that's the other message, that it does take work. And I know you have spent a lot of time and effort in learning to manage it and take it step by step, pacing yourself. You can't do it all at once. And it's about improving your quality of life and living with it. But it takes time and effort. And I think sometimes we don't get that message across well enough, that it isn't something like a pill. You take a pill and it's worked in half an hour. This can take weeks, months before you feel you're on top of it and have a handle on it and are back in control, as you say.
Yeah, absolutely. It's not a quick fix. I mean, I've been doing meditation and mindfulness for 3 years now, and it is a massively impactful effect on my life. But some days I'm really bad at it. I mean, it's called a practice for a reason. But I see it improving my life in other ways. Nothing to do with the pain. I worry less, just about everything. And that, again, it took time. That was, after a couple of years, I think I sort of really noticed that was happening, that I was just more chilled out. And I've obviously, in the last 3 years, another part of my story is that I've been having some issues with coming off the drugs. Well, I was put on a very high dose opioids for a long time, and a tricyclic, and it's been challenging to come off of them. So it's been very useful for that as well, to sort of allow you to sit with discomfort a little bit better. We're not, as a human race, we're not very good at sort of accepting discomfort, are we? Although with trigeminal neuralgia, it's a little bit more than discomfort. I don't mean to sort of downplay anybody's pain, because hello, I know what it's about. But yes, all these things, and I describe it almost like a picnic. Self-management. It's not just about that one thing. It won't just be one thing. It will be a whole smorgasbord of things that you will try, and what works for me might not work for somebody else. And it's about committing to finding what works. And yes, but it's an element of outcome independence, as they call it. But doing something not because it's going to reduce the pain, but because it's going to improve your quality of life. often then does reduce your pain, but it's not the main aim of it.
Yeah. And I
So,
think that's the very important message, that I think some patients go in thinking that doing a pain management program is going to stop their pain. It's about how it changes your attitude to pain, and therefore you get on with other things and then you don't notice them. It's like sleep. If you don't sleep well, then of course you're going to feel bad during the day, therefore you're going to feel your pain much more. You improve your sleep and you'll suddenly feel your pain's better, and it's because it's the sleep that has been improved. And I think that goes with a lot of aspects of it, that it is about improving other things that therefore lead to a better quality of life. And I think we always think of pain as measuring it in terms of intensity and strength, but I think the real outcome out of a treatment should be improved quality of life. And I'm hoping that that's what our patients will tell us. We're just doing some work around that. We've got a PhD student who's looking at outcomes for patients with trigeminal neuralgia. And of course, they all say pain relief as the number one, but we're beginning to see how people think through and realize that quality of life is the real essence of it, getting back to doing activities they love doing.
Yes, we come back to control as well. If you think that you can manage the pain better, your response to the pain better, you can improve your quality of life. I know I used to get, it was sort of trigeminal neuralgia, but it used to end up being almost like a migraine on top of it, and it would be pretty catastrophic for me. And I later found that a jab of sumatriptan actually helped it a lot, and having that escape medication freed me up a lot, so I could start going back to was passionate about national hunt racing, so I could go to Cheltenham again, because I knew that if I got an attack, I could slip off to the medical centre, jab myself, in 20 minutes I'd be back on course feeling better. These days I have the same headaches. I get out on my bike. I don't take any medication at all. It's, but that's again taken 3 years of hard work to get to that stage. But yeah, I find that a lot of my loss of quality of life was because it wasn't almost the pain, but it was the fear of the pain coming on and causing me to be in a vulnerable situation. And it's that vulnerability that was very hard to deal with as well, I think, especially because people find it hard to understand, don't they, with the level of pain,
and
when
the
it's
more
invisible.
Yeah, it's invisible, and the more severe the pain is, the more likely it is. And as we've discussed before, because the face has such a huge representation in the brain, it's felt so much more. And that's what I often explain to my patients. Look, if I put this pin in your big toe and then I put it on your tongue, you're going to tell me that it hurts more on your tongue, even though I've used exactly the same amount of pressure. It's because of the homunculus representation, because our face is just so important for communication. It's such a sensitive part. And as Deborah Padfield, my visual artist, has shown so much, the face is our way of communicating. And if the face also hurts, it's a double whammy, that here you are with a face that you can't move and people think you're okay. Well, there's nothing to see. Of course, there isn't anything to see, because we know it's an invisible pain. But you can't even express it because your face hurts so much. And that's a double whammy.
Yes, it hits your sense of self very, very hard in a lot of ways. The homunculus will put a picture of that up, the sensory cortex, because it's fascinating to see how much is, and that feeds into the fear as well, because the bigger the representation in the brain, the more fear is involved in it. So again, you see why the fear is a natural response to this pain, but of course it's not helpful. But wrangling fear is quite difficult, and hopefully we're going to do something with Chris, the psychologist, to give people some ideas of what to do about this. Is there anything else you'd like to cover while we're...
I think the big item is that we need to be aware that not everything is trigeminal neuralgia as well, that there are a lot of other pains. And I've just been doing some work with medical students trying to find out what happens in general practice, because I sit in a way in a bit of an ivory tower in my academic life, and I see patients who've sort of been through a lot before they come to us. But even in primary care, what is interesting is that GPs tend to overdiagnose in a way trigeminal neuralgia because it's something they've heard of. And sometimes they come to the diagnosis without actually even having enough of the information. The students were just looking at the records, and I gave them 6 things that you need to know if you're trying to diagnose trigeminal neuralgia. And there was only, out of the 12 patients that they found that had trigeminal neuralgia, only 1 had been asked, or at least the answers had been recorded, that all 6 of these questions had actually been asked and recorded. So it's also the way you present, the way you tell your story, that is often very important, and moves some ideas in GPs' minds, because I think that's the important thing, that GPs have a bigger understanding of chronic pain and its devastating effect, and know where to refer these patients when necessary. In this group, half the patients had been referred on, whereas the other half hadn't. So I think also GPs need to become more aware of these devastating pains and the need for more care. And I think the NICE guidelines of primary chronic pain that have just come out do emphasize that point. I know among pain physicians, there's a lot of disagreement, you're taking away our drugs and things, but I think it is putting more focus on the need for a psychosocial approach to chronic pain. Particularly, I'd say in the early phases, it shouldn't be at the end, which is what happens so often. Oh, well, you failed everything else, therefore you can have a pain management program. We run ours right at the beginning, and I think that is the crucial message. And GPs need to be aware that patients need support, and they can organize this in their practices. I think now back pain is very much more managed in primary care, and a much better understanding that it doesn't always need to go into the secondary care sector. So it's about raising awareness of the different forms of facial pain and the role potentially that dentists can play. And I think we sometimes forget that dentists are very well trained in the face, and they can exclude any dental cause. And I've been embarrassed before now with pushing more drugs for a patient with trigeminal neuralgia and then finding, oh, wait a minute, they've got an abscess. No wonder they're in a lot of pain. So it's about working closely with dentists, and there are some fantastic dentists out there who diagnose and recognize trigeminal neuralgia because they've taken a little bit more time to ask the pertinent questions, and importantly, have excluded a dental cause. And I think that, again, has got to be an interplay with the GPs sending patients to the dentist to check out that there isn't a dental cause, because dental causes are the most common causes of pain. And of course, in the secondary care sector, we've got the advantage of what we call the retroscope. I've got a longer history. I've got patients who have obviously had pain for more than 3 months. You just don't get referred to our center if you haven't. But that first attack of trigeminal neuralgia is more difficult to diagnose by a GP or a dentist because you haven't got the retroscope, you haven't got the time of it, you haven't got enough of a history, the patient hasn't been asked endless questions and thought about it. So I think we need to help both GPs and dentists to be better and to have the tools to manage facial pain, all forms of facial pain.
Yes, I'd agree. I mean, when I mean, it's going back quite a few years now, but when I first went to the GP with my facial pain, he didn't have a clue. He thought it might be my neck. I actually, when I was actually referred to a neck person, it's gone out of my head. And he actually diagnosed me with trigeminal neuralgia. He said, okay, there's nothing wrong, because I have an old whiplash injury, and he's like, no, it's not that. This is trigeminal neuralgia. You need to see a neurologist. And so I went on like that. Do you think people with who are diagnosed with TN need to Sorry, did I drop out?
Yep.
Do you think they need to have an MRI scan?
I think nowadays, yes. I think many years ago, MRI scans were very expensive and they weren't as well focused. But I think now it does help to have an MRI scan. There are a very small percentage, but there are the odd patient who will have a small tumor. It's not often malignant, but it is benign, but they can grow quite big before they're diagnosed. So our policy is, yes, an MRI for all patients with trigeminal neuralgia to exclude that. But I think what is very important to say is that you might show a nerve compression or a nerve contact. Nerve contact on its own is not diagnostic of trigeminal neuralgia, and it's got to be really much more of an indentation and a distortion of the nerve, and the history has got to fit, because 25, even up to 40% of people in the street will have a contact of the nerve and the vessel. So MRI is not diagnostic. It's not used for diagnostic purposes. It's used to exclude both MS, which is another thing that we find sometimes, and small benign tumors, to pick those up earlier. So our policy is, yes, an MRI for all patients with a potential diagnosis of trigeminal neuralgia.
So I actually, when I was working on the TNA helpline years ago, I had somebody who'd had a TN for 8 years and she hadn't had an MRI, and when she did, she had a tumor, and then that was removed and she was fine. So that was sort of quite frustrating that she'd suffered sort of unnecessarily for all this time, and it could have easily been ruled out. But there you go. But it's interesting about the fact that other people have not compressions, but contacts, blood vessel contacts, and don't have TN, because it's the same with back pain, isn't it? You have people with bulging discs who have no pain. It's not. It's Lauren and Mosley call it wrinkles on the inside. So that's good.
That's right. That's right. So it's got to be the history, and at the moment for pain we have no biomarkers, and at the moment it is all about how you tell your story and the pain. And as you've said, pain is real. And that's something, yes, it is in the brain, because if you didn't have a brain, you wouldn't feel pain. But the brain controls everything, controls your breathing, controls your heart. The brain is the powerhouse, and everything has to go through there, as does pain. But it doesn't mean it's all psychological.
But it does. But equally, psychology can be of great assistance to you, as can be brain training and stuff. But that doesn't mean that it's not real. We had Irene Tracy on a while ago at the festival, and she was talking about the sort of neuroplasticity of the brain, and that you can do great things with neuroplasticity, change both ways, but positively, to change things and to change your pain. But some people need a bit of extra help, and they've got stimulation through the skull that's actually sort of helping people sort of get a step up for the neuroplasticity. So there is a lot of hope out there for people that's coming. And you talked about some new drugs potentially coming for TN.
Yes, there's we had one that we've done a what's called a phase 2 trial, Zakrzewska. Unfortunately, at the moment it's been put on hold, but I hope it will be resurrected. And there is now another drug company that have got another molecule that we're going to be testing. So it is good news to hear that there are new drugs, but also, as you said, this neuromodulation of changing the way that our nerves connect up and changing the connections because they've got stuck in one road, and it's about trying to unstick them and put them back. We're not very good at it yet, but I think hopefully we will be coming, and that would get rid of the need for drugs even, because it would be really just addressing the way that nerves are moving. But we're still not quite there. But as you say, there is a lot of hope out there for work being done. It just needs a bit more funding at times.
I ended up with the motor cortex stimulator for my trigeminal neuralgia, and it helped about sort of 30% possibly, which is great. You know, you'll take anything, but I have found what I've been able to do myself has been far more effective than that. And I actually turned the stim off accidentally a year ago, last April, and had a flare up and thought, oh yikes, I'm having flare up, but I hadn't realized I'd turned it off, you see. And I just, you know, did more work and, you know, didn't get frightened by the flare up and just kept going and back to what is my normal baseline now. So you know, again, that gave me a huge amount of confidence, because flare-ups is a big problem with TN, but with any chronic pain, is that they can become very scary. And of course, once you start getting frightened of them, it tends to prolong them. So having, again, we're going back to control, having a plan to deal with flare-ups is very useful. So I mean, you talk to your patients about having a flare-up plan. You mentioned before about being able to ring. And
that's right. I think that's the important thing, is having a flare-up plan and accepting that you will get them, that they do happen, but it's not your fault. And I think that's the other thing, isn't it, is accepting that we don't know why they occur. I mean, sometimes we think that it could be the pressure of the vessel on the nerve that causing the loss of insulation. We sometimes put it down to that, but we can't be sure. So we don't often know what is the cause for a flare-up, but it's again that neuroplasticity of the brain changing, and it perhaps reconnecting to old connections which it had forgotten about, and that's why, and trying a variety of different ways of overcoming it is very important.
Yeah, it's fun. Not really, but there you go. But I mean, pain teaches us a lot of things as well, and you know, I don't think it was the cause of my TN, but when I look back, I was working in London. I was working extremely hard. I was playing extremely hard. My lifestyle was not really healthy in some ways, and I think that now I have a much better sort of balanced lifestyle, and I've still got some way to go. But you know, it's actually, again, it's the reframing. It's looking at things in a different way, isn't it? And finding ways to move forward, and that's very hard with pain, because you've got to grieve the losses.
Yeah. And potentially change direction. I think a very good example is my visual artist, Deborah Padfield, who was a drama person and things, but when she got her pain, couldn't do it. And yet she's revamped her whole life into the visual arts and pain management. She's done a PhD, postgraduate. I mean, her whole life has completely changed in a very positive way, as a result, in a way, of the fact that she had to change pathway because of her initial pain. So pain opened up a new window for her, and she made use of it, and yes, again, lives with her pain, but has done so much for the world of pain and helping people to understand it in a more visual way rather than just through words. So I think that's the positivity of it, that pain can be a positive thing for putting you out of your usual pathway, telling you, wait a minute, reflect, think about your life. Perhaps you aren't doing the right things, and perhaps you do need to do something different, and that different can be even more positive than what you did before, but in a different way.
Yeah, and I mean, that's not to say it's anybody's fault that you've developed the pain, but it's using it as an opportunity, because these things happen. We have to learn to live with these things and find the positives in it and stuff. I mean, I regret not being able to have kids because of my condition, but I've learned an awful lot about animals and training animals, and that actually really helped me recover from the pain, because I used a lot of that knowledge to help to decondition with the graded exposure, and because I linked the graded exposure with positive reinforcement as well, which really helped make it very effective. So it's just being flexible and creative enough, but that is hard when you're in pain, and again, that's why we need to, as a community, work to support people to be able to make these changes and to see these different ways of looking at things. And I think your visual artist is a great example of that. Okay, and anything else you'd like to?
No, I think we've covered enough ground to give some people some thought and reflection, and I'm very pleased that I've had the opportunity to talk to you. And I think talking to you particularly as a TN sufferer who really understands and has come out at the other end, I think is such a positive message to give to our patients, that it isn't all doom and gloom when you get that label, that there is light at the end of the tunnel, and that things are moving along. So I'm very grateful for the opportunity to get that message across with you, because I think your story is so important. It's, as my patients say, you've never had TN, you don't know what it is. It's a buddy there, and you've been that buddy to say to TN patients, I've been there and I've done it, and you can get out. And I think that's an important message we've got across, I hope, today.
I hope so too, and I'm extremely grateful for you giving us your time. It's been wonderful, and I hope it's given people a real sort of understanding of what's going on, and how important the other aspects other than just medical are, and to to see a physician who actually really understands it as well. You might not have TN, but you've seen enough people to understand the kind of journeys that people have. So thank you so much.
Right. Okay, thank you. Bye-bye.
Bye-bye.